Okay, there we go. So this is the last part of the chapter, and here we're gonna emphasize the oral hypoglycemics for type 2 diabetes. By oral, medication is PO. So let me share what's going on here. Share screen. Okay, so I'm gonna start on the order that oral hypoglycemics were given to patients. The first group of oral hypoglycemics ever given to a patient, a diabetic patient, is the sulfonylureas. As a highlight, for adverse effects, sulfo sounds like sulfur, and sulfur burns with heat. So this medication, BMPO, the best way to take it is with an empty stomach. But unfortunately, type 2 diabetes is a chronic disease. So the best way would be with water. If the patient complains of a gastric upset, then, take it with meals. But regarding the term sulfur, like I mentioned, sulfur burns with heat. So this type of patients, when they take the medications, eventually they're gonna have sunburns. So we need to highlight and we need to emphasize the use of sunscreens, hats, and long sleeves. So guys, telling you, sulfonylureas was the first anti-diabetic drug used for type 2 diabetic patients. And the way it works is by promoting more insulin release. So if you remember from the first video, I told you that type 2 diabetic patients, the problem that they have is the cells of the body, they don't react to insulin. So this drug, or the purpose behind it, let's give more insulin. So it's like that teenager that uses a perfume cologne. After a few minutes, they don't smell it anymore, so they put more so they can continue smelling it. So that's a overstimulation of the ophthalmic nerve. So here, that's the same purpose. We want to overstimulate those cells, and that's how sulfonylureas work. They release more insulin. Eventually, the cells will just give up, like, okay, you win, and they'll open those doors for glucose. But the problem is that the intake of glucose now to the cells is too fast. So hypoglycemia is very common with sulfonylureas. Very, very common because it's a fast drop in glucose. And the other one is weight gain. And for a type 2 diabetic, we don't want that. We want to prevent the weight gain. So why they're gaining weight? The thing is, when a cell has glucose and it's not using it anymore, it's going to store it. The first way of the cell is going to store glucose is to convert it into glycogen. And that glycogen goes to the liver. Unfortunately, the liver is not that big for storage. So only a small amount is converted into glycogen, but still the cells, they have sugar that they need to store. And that will be converted now into adipose tissue, fat tissue. And that's how the patient gains weight. Type 2 diabetic, that's not the best thing to happen. Sulfonylureas are divided in two generations. The first generation, as you can see here, tolbutamide, tolasamide, you can see they start with tol and they end with amide. So that's a way to identify sulfonylureas first generation. Second generation is a big twist on the names because now they have glee. lipicide, glyperide, they start with GLI. GLI for glycemia. Sounds like glycemia. And this become a rule for oral hypoglycemics. All medications for diabetes, type 2 diabetes, they're gonna start with GLI. So on the second generation, we're starting to see this. The other thing that happens, especially with the first generation, is cardiotoxicity. They interrupt or they alter the action potential, not the action potential, but the electrical conduction, sorry. They alter electrical conduction of the heart, and that will produce arrhythmias. That's the reason the first generation of drugs, sulfonylureas, is not used anymore. Second generation, uh, they don't have cardiotoxicity like the first one. Regarding drug interactions, besides don't mix it with other hypoglycemics, is what other drugs interfere those levels. So if you remember, we mentioned beta blockers and beta agonists. Beta agonists stimulates glucose. Beta blockers, they inhibit glucose. So if the patient is taking any of these drugs because of heart issues or asthma problems, stuff like that, when it's a beta agonist or blocker and it's a diabetic patient, we need to emphasize that they need to recheck their glucose levels at least 3 times a day until they adapt to this new uh, regimen of drugs. Okay, we're gonna jump back a little bit, and now we have the biguanides. Here, the main one is the metformin. Metformin is the main drug used for type 2 diabetic patients. This medication, instead of releasing more insulin like the sulfonylureas, this one is gonna stimulate or sensitize the cells in order for them to take insulin in. So metformin works with the cells, it's gonna sensitize them so they can take glucose in. The tissue that they love the most is muscle cells. Metformin works a lot with muscle cells. So the insulin in the body is not gonna change, still the same one. So the hypoglycemic effect is not as severe as the first group that we mentioned. So the chances of hypoglycemia with metformin are less likely. The other part is because they're working with muscle cells and the muscle cells are using this glucose for energy, we have an increase in lactic acidosis. Remember, that's a waste product from energy. When a muscle uses energy, the waste product is lactic acidosis. And because metformin favors muscle cell in order for them to take glucose, we have an increase in this acid. The thing is, and we have to make sure that the patient doesn't have kidney failure. If the patient has kidney failure, this acid is going to have a harder time to be eliminated from the body. So the patient is going to go into an acidosis state, and that can be fatal for the patient. Metformin can be used also for gestational diabetes, like it states down here, and for a polycystic ovary syndrome. And this type of syndrome, the ovaries, they have a lot of cysts, and they altered the hormones of the female body, increasing glucose levels, increasing cortisol. Cortisol increases glucose. So by providing metformin, we can block the effects of cortisol, and we can have a better glycemic control on this patient. Now, metformin recently, this is not something has been used a lot. It can be used on those patients stuck on the gray zone that we mentioned regarding the values of glucose between 100 and 125 milligrams per deciliter. So you have a patient stuck there that even though making lifestyle changes, diet and exercise, they're still there. We can give them metformin before they get type 2 diabetes, before they get all those complications of type 2 diabetes long term. Uh, metformin is banned from the Olympics. This is a little side story regarding metformin. Like I mentioned to you, metformin favors muscle tissue in order for the muscle to get those. So when metformin came out, it was used by athletes to have a better physical performance. So just before the event, they'll take the metformin and they'll do better. So when the judges, they noticed this, they ban it from the Olympics. So on that blood test that they do on the athletes that they get the first, second, and third place, metformin is part of that panel that they're looking. Okay, now let's do a big jump over here, and we're gonna continue now with the meclitinides, sorry, or the glinides to make it simple. So this is another group of oral hypoglycemics, but they follow the GLI part in their name. That way, even though you cannot remember exactly is that a sulfonylurea, is that a glinide, just because you are able to identify GLI in their name, you know this is an oral hypoglycemic. The glinides, just like metformin, they're well tolerated. The adverse effects in this case is hypoglycemia because just like the sulfonylureas, they increase the amount of insulin. Not as drastic, but still they'll increase insulin in the patient's body. The next group is thiazolidinediones, glitazones, that's way faster. And we call them glitazones because the generic names, they have glitazone in their name. And same thing, yes, if you don't remember the whole thing, glitazone, glinide, just remember, if you see GLI, it's an hypoglycemic. The most common adverse effects can be hypoglycemia. This one, the glitazones, when they came out, they were amazing. They were the main drug. They were pushing metformin out of the way because it was amazing. The problem is, after a year, more or less, they start having serious adverse effects, like respiratory infections in the lungs, destruction of muscle, weight gain. So based on that, they were bumped from first option, and metformin became again the number one drug for type 2 diabetes. So pioglitazone, just like rosiglitazone, they are used on patients that the doctors having trouble controlling glucose levels. It's a type 2 diabetic patient that started with metformin. After a few months, maybe a year, we still see that the patient making changes in lifestyle, taking the metformin as prescribed, still glucose levels are high. Then the doctor will add rosiglitazone or pioglitazone for 6 months, more or less. Most of them will get control by then, and then it's removed and continue with metformin. The last drug that we're going to be talking is the alpha glucosidase inhibitors. And like the name says, this drug, wasn't supposed to do that. Okay, there we go. So this drug is going to inhibit the enzyme, as in NAs, alpha glucosidase. The function of this enzyme is to absorb carbs. This enzyme is in the intestine and is in charge of absorbing the carbs from our diet. So acarbose, this is the main drug from this group, acarbose blocks the enzyme. By blocking the enzyme, the patient cannot absorb the carbs. Now, regarding the use, usually we use it on uncomplicated patients, patients that every now and then they will have troubles controlling glycemic index, their levels, and we'll provide Acabur for a couple of months, and then they'll go back to normal. As you can see, the adverse effects, it says flatulence, cramps, abdominal distension, and so on. So for you to remember faster, sugar is not going to be absorbed. It's going to stay in the intestine. So when glucose is not absorbed and it stays on the intestine, it's going to get fermented. It's going to go to a process of fermentation. That means that it's going to start having a lot of gas, a lot of production of gas. And that's where the flatulence come in, abdominal cramps, abdominal distension, a lot of burping, diarrhea. And diarrhea because, you know, this gas is trying to get out of the body, starting to move. Unfortunately, this fermentation process, again, because it's inside the intestine, and the function of the intestine is to absorb what is inside the intestine, some gases will get absorbed, and that will produce liver damage. It's not a very common thing to happen when it's used on short terms. But we have a patient that they want to base their diet just on this drug, then those patients will have liver damage because of that absorption of those gases that they're not supposed to be absorbed. Okay, I will mention just this one over here is one of the newest drugs, DPP-4 inhibitors, gliptins. So you can see they have the name Glee, sitagliptin, Januvia. It's quite a newest medication that is used. This one's also inhibit an enzyme that helps release insulin. That stimulates the release of insulin from the pancreas. The reason that they're not used that much so far is because they have seen that saxagliptin promotes infections of the lungs and UTIs. Now regarding oral hypoglycemics, well, same thing, you have to tell the patient that every time they take a oral hypoglycemic, it's gonna take between 30 to 45 minutes for the medication to start working. That's more or less the time frame for the body to absorb the medication and get activated by the liver. So they have to make sure that they eat after taking their drug. Regarding drug interactions, I emphasize careful with the betas, agonists or antagonists. If the patient has a beta in oral hypoglycemics, we need to emphasize to those patients, because now you're taking another drug that is gonna change your glucose levels. Start checking your glucose levels more often until you comfortably have control. Okay, so we are done with this chapter. Okay, I'll see you on the next one.